Hey there, welcome back. We're diving into some pretty profound territory today. I'm excited to really get into this one.
Yeah, it's an area I think a lot of folks have a strong personal connection to, but maybe haven't thought about from all the angles we're going to explore.
For sure, and that's why I think the source material is so fascinating. We're looking at the Stanford Encyclopedia of Philosophy entry on pregnancy, birth, and medicine.
It's a pretty dense entry, but that's what we're here for,
Yeah.
right? To break it down and have a real conversation about it.
Exactly. And what jumped out at me right from the start is how this entry goes beyond just looking at pregnancies with complications. It really examines how even normal, healthy pregnancies and births have become so medicalized in our society.
I think you hit the nail on the head there. I mean, it makes you question what we consider the standard experience these days, what's natural anymore.
Right. And that's one of the big themes we're going to unpack in this deep dive. The ethical considerations, the impact on women's autonomy, how reproductive risk is managed within this whole medical framework. It's a lot.
Absolutely. There's a lot to think about philosophically. I mean, when we even say medicalization, what do we really mean?
Well, the entry refers to Amy Mullen's definition, which basically says that medicalized pregnancy interprets this totally natural process as, like, a health disruption. It's seen through a health illness lens, and expert medical intervention becomes the default.
So right away, we're seeing that this isn't just about biology, it's a social process too, right?
Definitely. It's influenced by our institutions, our healthcare systems, even our cultural beliefs.
Which means it's not inherently good or bad. There are benefits and drawbacks.
Like the entry points out, medical interventions have drastically reduced risks like death from placenta previa or ectopic pregnancies. I mean, those are huge wins, no doubt.
Of course. But on the flip side, think about all the routine interventions that have become commonplace, even without always having tons of evidence to back them up.
Yeah, like continuous fetal monitoring for low-risk pregnancies, the lithotomy position for birth, which might not be ideal for everyone. And I remember when routine episiotomies were a thing. Those have all been criticized over time.
And that criticism is definitely growing. More people are pushing back against what they see as over-medicalization.
Right, there's this movement to demedicalize what's considered normal, to bring back the role of midwives, who often take a less interventionist approach.
And it gets more complex when we bring in the connection between over-medicalization and, this might be tough to hear, but misogyny.
Yeah, the source does bring up some tough stuff there, like situations where women's autonomy isn't fully respected, lack of informed consent during childbirth, and, I hate to even say it, the concept of obstetric violence. It suggests a real power imbalance sometimes.
It's disturbing. And then there's how medicalization shapes our social expectations. The entry talks about this expectation for pregnant women to basically manage their lives by medical guidelines.
Right, their diet, sleep, the baby's movements, everything. It's like this intense responsibility to control everything.
Which often means relying on a lot of technology. Genetic testing, ultrasounds early on, then during labor, inductions, epidurals, constant monitoring, and as we're seeing more and more, cesarean sections.
And that rise in C-sections is definitely debatable. Some people see it as overuse of technology, potentially driven by convenience or fear of litigation. And Rebecca Brioni, who's cited in the entry, makes this interesting point about how all this tech can almost make the mother feel less responsible. Like a safe birth is solely in the hands of the medical professionals, not her own body.
It's this subtle shift in agency. And it's crucial to remember, as the entry stresses, that the benefits of medicalization aren't equally distributed. The disparities based on race and socioeconomic status are really alarming.
Absolutely. Black and Hispanic women face higher rates of neonatal death and stillbirth, and the maternal death rates for Black and Asian women and those in deprived areas are much higher. It points to a bigger problem with justice and equitable access in our medicalized healthcare.
Which brings us to the heart of it, the ethical effects of this medicalization. It's changed how we see pregnancy itself. Instead of a natural life event, it's seen as this inherently high-risk, almost pathological process.
And that perception can really undermine a woman's own knowledge and intuition about her body.
Yeah.
Her epistemic privilege, as the source calls it. It can make her feel less empowered, more passive in her own pregnancy.
And the advice often focuses solely on her behavior, avoiding harm to the fetus. It's like she's solely responsible for any negative outcome, even if there are other factors at play.
It puts so much pressure on the individual and all this risk management and constant surveillance. I mean, it can make the whole experience feel more alienating, more stressful.
No wonder there's this pushback. The natural birth movement is a direct response to that. The desire for less technology, more reliance on midwives. It makes sense.
But from a philosophical perspective, the source also raises some cautionary points about this movement, doesn't it?
Yeah. What exactly do we mean by natural? Why is one form of pain relief okay, but not another? Is natural always better? It's not always so simple.
And as they point out, the natural birth movement can create its own set of pressures and rigid expectations. It might not acknowledge the very real need for medical intervention in certain situations.
It's about finding that balance, recognizing the complexity. And as Chervenak and McCullough say, the alternative to medicalized pregnancy isn't necessarily a completely natural one. Technology is likely here to stay. It's about how we use it.
Okay, so let's dive into some specific ethical issues within obstetrical care. The first area the entry addresses is prenatal diagnosis and screening. It's become so commonplace now.
From those early ultrasounds to the array of blood tests, the MSA-FP, and all the genetic testing options that seem to be expanding all the time, the ability to screen for more and more conditions is constantly growing.
So, on the surface, one of the arguments in favor of prenatal testing, PT, is that it gives women more autonomy, more information, more choices about their reproductive lives.
But the entry quickly pushes back on that.
Right.
It asks whether this really translates into genuine autonomy. There's this pressure to accept these tests, this sense that it's the responsible thing to do.
And often the only option after a positive test is abortion. So it's this heavy burden of choice. It can make it feel like women are expected to produce socially acceptable children, and their bodies are constantly being monitored and judged.
There's this research by Press and Browner that shows how women feel this pressure, this expectation to make the responsible choice, even when it limits their options. It can really narrow down the choices that feel acceptable.
So PT can be this double-edged sword. It can be empowering to have more information, but it can also create this pressure to conform, this narrowing of choices. And it can affect how women connect with their developing fetuses, knowing so much about them so early on.
And what about the implications for the children themselves? The entry raises some ethical concerns about how widespread PT could shape our expectations of children. Will parents develop these unrealistic, idealized expectations based on prenatal information?
Will love become conditional on a child meeting certain criteria? It's almost like we're setting them up for failure before they're even born. And the entry touches on this really fascinating philosophical puzzle, the non-identity problem.
This one's a mind bender. The basic idea is that you can't actually harm a non-existent person by bringing them into existence, even if their life will be challenging.
So, for example, in the case of selectively aborting a twin with an anomaly while the other twin is healthy, can we say we're harming the child who wasn't born? They wouldn't have existed otherwise.
Or think about a woman who takes medication that could cause birth defects if she gets pregnant. Should we tell her to wait? The child born with those defects wouldn't have existed without the medication.
It's so counterintuitive, right? And then there's the case of deaf parents who intentionally choose to have a deaf child. The argument is that it can't harm the child because without that choice, they wouldn't exist at all.
It raises some serious philosophical questions about what constitutes harm in these situations. Is it wrong to intentionally bring a child into the world who will face challenges?
The source points out that a lot of people have a strong intuition that it is wrong, that it limits the child's potential. But the non-identity problem challenges us to really justify that intuition.
There are a few different philosophical responses. Some argue there is no direct harm to the child, others that the wrong might be on a broader social level, or that the non-identity problem isn't relevant in real-life decisions.
It's a deep rabbit hole, and this leads into the social concerns and the disability rights critique of prenatal testing. There's this worry that it's a form of eugenics, right?
The source distinguishes between what they call top-down eugenics, like those horrible state-mandated programs of the past, and bottom-up eugenics, which is more about the cumulative effect of individual choices.
So even without a deliberate plan, if everyone is choosing to eliminate certain traits, it could lead to a loss of diversity, a homogenization of the gene pool. And the tests themselves reflect what society values. They reinforce the idea that some traits are good and others are bad.
And then there's the expressive meaning argument, the idea that by offering these tests and the option of selective abortion, we're sending a message that the lives of people with those conditions aren't valuable.
And the disability rights critique goes further, arguing that PT and selective abortion further stigmatize people with disabilities and harm existing disability communities. It
Yep.
reinforces this medical model that sees disability as a problem to be fixed rather than a natural part of human variation.
There's this concern that by focusing so much on preventing disability at the prenatal stage, we're neglecting our responsibility to create a more inclusive and supportive society for people with disabilities. And as some disabilities become less prevalent due to selective abortion, those who do live with them might face even more isolation and lack of resources.
The source also points out potential biases in genetic counseling itself. Counselors might not have enough exposure to the lived experiences of people with the conditions they're discussing, and they might not fully address the available social supports.
The idea of disability competencies for genetic counselors is gaining traction, recognizing the need for more nuanced and informed guidance. There's also this concern that PT encourages this commodifying, perfectionist view of children, parents wanting the perfect baby, potentially leading to conditional acceptance based on prenatal diagnoses.
Saxton argues that it's not disability itself that's burdensome, but rather the lack of social support. But we can't ignore the real challenges that raising a child with a disability can bring. It's tough to find that balance, you know?
And where do we even draw the line with testing? What's a serious enough condition to warrant testing? How do we avoid medicalizing things that are more about social constructs than actual harm? It's a slippery slope.
And on top of all that, there are all these additional ethical considerations. Insurance coverage, parental rights to test for things like sex selection, and what to do with all the genetic information we're gathering.
It's a lot to unpack. And then moving on to the actual birth experience, we run into this tension between the medicalized view of childbirth and the natural birth movement.
Is birth inherently dangerous, requiring expert intervention, or is it a normal physiological process that should only involve intervention in emergencies? It's a pretty fundamental debate.
People advocating for more natural births point to what they call the cascade of interventions that can happen in hospitals. One intervention leads to another, and it can make the whole experience feel very medicalized, very controlled.
They worry about losing that sense of agency, that dignity. But on the other hand, the natural birth ideal can create its own pressure. It can make women who need or choose interventions feel like they've failed.
It's not always so black and white. Lyerly makes a good point that it's not necessarily technology that's the problem, but the power dynamics, the expert-centered culture that often exists in hospitals.
It's about feeling respected, feeling like you have a say in what happens to your body. And Emily Martin compares choosing home birth or resisting certain hospital protocols to acts of political resistance.
There's this sense of pushing back against a system that feels disempowering, dehumanizing. The source talks about the widespread reports of disrespect and loss of autonomy during childbirth, and it's really disheartening.
And it's not just over-medicalization, it's also about deeply rooted societal expectations of women, this idea of maternal sacrifice and the stereotype that they're not reliable in managing their own health.
Midwife-assisted or doula-supported deliveries are often presented as a more respectful, less interventionist alternative. But those who support the medical model, they emphasize the potential for serious complications that require immediate access to hospital resources.
The debate around home birth gets particularly heated. Some ethicists argue that doctors should refuse to attend home births because they prioritize the parent's desires over the fetus's well-being. And in some countries, home births with midwives are actually illegal.
But even critics of home birth acknowledge the evidence suggesting benefits for low-risk pregnancies. Less pain, more satisfaction, fewer interventions. It makes you wonder if maybe some hospital practices are pushing people towards home births.
And then there's the whole issue of cesarean deliveries on maternal request, CDMR. The medical evidence doesn't clearly favor either vaginal or cesarean for low-risk births.
And without clear guidelines or long-term data, it's hard to fully assess the impact of elective C-sections. Some worry about a technological imperative driving the rising rates, even when there's no medical need.
And that too posh to push stereotype is so dismissive. It ignores the valid reasons why a woman might choose a C-section. The term elective can be misleading too, because it's often a choice made within a complex context of personal circumstances.
Some see offering CDMR as enhancing autonomy, giving women more options. But others argue that it's not just about having choices, it's about the context in which those choices are made. They worry that routinely offering C-sections normalizes medicalized birth and influences preferences based on doctors' authority.
And finally, we have this whole discussion about the fetus as a patient. When does the fetus become a patient with its own rights? How do we balance the needs of the mother and the developing child?
Chervenak and McCullough proposed that viable fetuses should be considered patients owed beneficence and respect for future autonomy. But some feminists argue that this creates a false dichotomy, pitting the mother against the fetus.
King Mema points out that maternity care is unique because it can involve harming one patient, the mother, for the benefit of another, the baby. And she says this sacrifice is often seen as normal, even expected, with less emphasis on informed consent.
The shift in language from fetal surgery to maternal fetal surgery is interesting. It acknowledges the mother's role. But even that might not fully capture the complexity of the relationship, and the very offer of these surgeries raises questions about societal expectations of maternal self-sacrifice.
It can make it seem like the mother's well-being is less important. Now, moving on to compromises of pregnant women's autonomy, the basic principle is that competent women have the right to make their own medical decisions, even if they conflict with what's best for the fetus.
But things get really messy when the woman's autonomy is compromised, either partially or completely. We're dealing with two beings who are interconnected, but only one has decision-making capacity.
And there's no easy formula for balancing their interests. The woman's prior wishes, her current well-being, the potential child's future. It's a lot to weigh.
In the most extreme cases, we have fully incapacitated pregnant women, like those in a vegetative state or brain dead. Should we keep them alive just to continue the pregnancy? Who decides? It raises some profound questions about life and death, personhood, and bodily autonomy.
Some argue that even in these cases, we need to respect the woman's dignity, her prior values. Others say it's wrong to perform an abortion on a brain-dead woman, even if that's what she would have wanted.
The idea of using a woman's body solely as an incubator is deeply disturbing to many. And these cases can reinforce the idea of the fetus as a person with rights that trump the woman's own.
It can lead to situations like court-ordered interventions on pregnant women, which is a huge violation of their autonomy. Smajdor compares this to whole-body gestational donation, making us question the consistency of our moral intuitions.
What about the father's wishes? What about the potential child's right to life? It's a minefield. And unfortunately, advance directives expressing a pregnant woman's wishes can sometimes be overridden for the sake of the fetus.
When it comes to women with decisional impairments like cognitive disabilities, mental illness, or substance use disorders, it's about balancing respect for their limited autonomy with protecting both them and the potential child from harmful choices.
It's tricky. These women are often vulnerable, facing barriers to health care and potential bias from doctors and family members. There's a risk of overestimating their impairment, especially if others disagree with their decisions.
The case of NHS Trust v. JP, where a woman with learning disabilities was forced to have a C-section that turned out to be unnecessary, shows how dangerous this can be. Tatima points out that decisional capacity isn't a simple yes or no, it's a spectrum that can fluctuate.
We have to find ways to support these women in participating in decisions as much as possible, providing clear information, involving supportive family, creating a conducive environment, and the presence of a fetus shouldn't diminish our duty to protect the woman's autonomy, even if paternalistic interventions might be necessary sometimes.
And then there's the issue of overriding autonomy, of forced interventions on pregnant women. The principle of refusing medical treatment, even life-saving treatment, it's pretty fundamental.
But that principle has been violated in the case of pregnant women, often to protect the fetus. Forced C-sections, mandatory HIV testing, blood transfusions against religious beliefs.
The cases of Samantha Burton and M. Swy, who was forced to have a C-section after seeking an abortion following rape, are really horrifying examples of this. These situations highlight the coercive measures that can be used against pregnant women.
Thankfully, forced interventions on competent women are becoming less common, but they still occur, especially among vulnerable populations. We have to remember that pregnant women have the same rights to privacy and bodily integrity as anyone else.
You can't force someone to undergo a medical procedure to save another person, even if that person is their fetus. And while emergencies might require waiving informed consent, that shouldn't be an excuse to disregard a woman's autonomy.
Forcing interventions can reinforce this idea of the fetus as a person with rights that supersede the woman's. It creates this expectation of maternal self-sacrifice that's not applied in other contexts.
Civiliscu argues that there's a moral duty to save a life when it's easy to do so, but others point out that moral duty doesn't justify legal compulsion, and calling it maternal-fetal conflict frames it as an adversarial relationship, which can be harmful.
While true conflicts can arise, in those extreme cases where a choice must be made, saving the mother's life has to come first. And if a woman autonomously chooses to sacrifice herself for her child, that should be respected.
The last section delves into managing and communicating reproductive risk. We're bombarded with risk language these days.
Pregnancy does have inherent risks, but the source argues that women bear a disproportionate burden in managing those risks.
Of course, women care about their children's well-being, and it is a public health issue. But effectively managing and communicating risk is really complicated.
The risks and benefits of different actions might not be the same for the mother and the fetus, which creates tension. And there's often a lack of solid evidence, which makes informed decision-making difficult.
Plus, cultural perceptions can distort how we see these risks, which can lead to decisions that aren't in anyone's best interests and put undue pressure on women.
Like with alcohol and drug use during pregnancy, there's this strong belief that any use is irresponsible, even leading to campaigns for total abstinence before conception.
But the evidence about light to moderate alcohol use is less clear-cut than heavy use, which definitely causes harm. So the question becomes, do even small potential risks create a moral obligation to abstain from everything potentially risky?
It's like, should women stop driving, playing sports, traveling? We can't eliminate all risk. Woolard argues against this idea of a general maternal duty to do anything that could benefit the fetus, no matter the cost to the woman.
It's not realistic, and it reinforces these gendered expectations of sacrifice. It seems like we need better ways to approach risk.
Armstrong and Golden even call the anxiety around fetal alcohol syndrome a moral panic. They argue it's more about cultural anxieties about mothers than about evidence-based risk assessment.
It's interesting how much focus there is on controlling women's behavior during pregnancy, often to the detriment of their well-being. And there's this real anger, this particular rage directed at women who use drugs while pregnant.
It ties into these deeply ingrained ideas about motherhood and purity. And we see it in attempts to prosecute pregnant women for child abuse or fetal endangerment, removing children at birth, coerced treatment.
There's evidence that these punitive approaches actually discourage women from seeking prenatal care and addiction treatment. It doesn't help anyone.
And studies have shown a link between these policies and higher rates of neonatal abstinence syndrome. It's like we're punishing women for struggling with addiction instead of offering support.
It all boils down to control and taking away women's agency, and it's not even applied consistently. Poor and minority women are disproportionately targeted, despite similar rates of drug use.
Young outlines 3 approaches to drug abuse during pregnancy. Punishment, which she rejects. Treatment, which she has reservations about because it's too individualistic. And empowerment, which she favors, focusing on addressing social inequality and giving women more control.
The last piece of the puzzle is research involving pregnant women. Historically, they've been excluded from clinical trials due to concerns about fetal risk and hormonal changes.
And that lack of research has real consequences. It means we don't have the best evidence to guide medical care for pregnant women.
The NIH changed its policy in 1993 to encourage the inclusion of women in research, but pregnant women are still often excluded as a vulnerable population. It's like this catch-22.
Excluding them means we can't develop safe and effective treatments for them. It leads to a lot of off-label drug use where we don't have solid information about risks and benefits.
And the general advice is to avoid medications during pregnancy if possible, but that ignores the potential harm of not treating certain conditions, especially mental health conditions.
The evidence against some commonly used medications, like antidepressants, is actually pretty weak. But without research, we just don't know for sure. It's a tough spot for doctors and patients to be in.
The entry calls pregnant women therapeutic orphans. Their medical needs are often neglected in research. It's like there's more focus on preventing any potential risk to the fetus than on ensuring the well-being of both the mother and the child.
The conservative approach focuses on the risks of intervention, but it ignores the risks of non-intervention. And without good research, women are left to weigh those unknown risks against each other, which is impossible.
Crafting ethical guidelines for including pregnant women in research is tricky. Fetal exposure to experimental treatments is a real concern, and many women understandably hesitate to participate.
The source suggests viewing both the woman and the fetus as patients, but it also acknowledges that this could still limit research, even for interventions that could save the mother's life. We need to find a better way to approach this.
We can't just assume that protecting fetuses from unknown interventions is always the best course of action. We need more research, more evidence to make informed decisions.
So we've covered a lot. We've explored the medicalization of pregnancy and birth, the ethical dilemmas, the impact on autonomy, and the challenges of managing risk. It's a really complex landscape.
And all of these issues connect back to core philosophical ideas: autonomy, personhood, harm, justice. These aren't just abstract concepts. They have real implications for people's lives.
Now, the question for you is, what philosophical framework makes the most sense to you in navigating this complex world of pregnancy and birth? Is it about individual autonomy, the potential life of the fetus, societal well-being? How do we balance those values?
There's no easy answer, but hopefully this deep dive has given you some food for thought. And if you want to explore these issues further, we highly recommend checking out the full entry in the Stanford Encyclopedia of Philosophy and the sources it cites. Thanks for joining us.